have the pleasure to be here with my esteemed colleague, Dr. Sundaram, and we're going to talk about upper tract urothelial carcinoma. Always a great subject for urologists, and especially for urologists talking about the surgeries we perform for upper tract urothelial carcinoma. And it being a rare disease, sometimes it's hard to do large studies, to see what we're doing as urologists. But he's had the pleasure to work with a great group of other individuals and going to tell us about some of his recent research about nephroureterectomy with focus on the bladder cuff.
We had the opportunity of collaborating with multiple other institutions across the globe, 17 institutions with over 1,700 patients who underwent robotic nephroureterectomy for upper tract urothelial carcinoma. So what we found was that patients who had a bladder cuff excised, they did do better with regard to bladder recurrence rate, but as far as overall survival rate and metastasis-free survival rate or cancer-specific survival rate, there was no difference. So the bottom line was the gold standard of excision of the bladder cuff still stands as the best treatment option for patients undergoing robotic or open nephroureterectomy for upper tract urothelial carcinoma.
Yeah, I think, that's very interesting, concept, and kind of reiterates what we've been practicing and what we teach, as urologists, the importance of that. And, you don't even necessarily get into this, but oftentimes when we talk about cancers, we do talk about overall survivals and cancer-specific survivals. But I think in this patient population, bladder cancer recurrence-free survival is a very impactful and patient-focused endpoint, that's important to us as urologists. Right? If we obviously have to scope these patients, in clinic, and decreasing the risk of bladder recurrences is highly important, from a financial standpoint and from a quality of life standpoint for our patients.
Absolutely. I fully agree with you. In fact, the bladder recurrence rate was 28% where the bladder cuff was not excised versus 23% where it was excised. So there was clearly a difference. However, as we all know, not all patients are the same. That's and right. There may be patients who do not have very high risk cancer, but with multiple comorbidities, elderly individuals. You want to get them off the table as soon as possible. Sure. And prolonging the operation by excision of a bladder cuff may not be ideal. So in those circumstances, I think the study does allow you to say that we can go ahead and accept that slightly increased risk of bladder recurrence rate since this patient has to get off the table and minimize immediate perioperative morbidity.
Yeah, I think that's an excellent point that, our overall drive as urologists, of course, is to do the very best that we can and to take that bladder cuff. And in the era of the robots and robotic surgeries that we have nowadays, it doesn't always add a whole lot of comorbidity for these patients, personally, in my own opinion. But there are those select patients, and as long as you can, I still believe taking that ureter down as low as possible to the bladder, right? So you're not leaving residual ureter there. Even if you don't take a formal cuff, which I think your study supports, that in that 80 plus, nearly 90-year-old patient with several comorbidities, it's not unreasonable to do that, and you're not risking a cancer-specific or overall survival.
That's a very good point. So whilst 90% of these patients did have a formal bladder cuff excised, so that is, sure, I think, important to know, and only 6% of these patients did not have a bladder cuff. 4%, on the other hand, other techniques were used, okay, like the pluck technique or the interception technique or the stapling technique. And to your point, those can be used. You can go down all the way to the intramural portion of the ureter and then staple right across it and minimize OR time that way as well, just like you did mention. So there are some interesting nuances in this study that allow us to do what's best for that particular patient without compromising survival, or for that matter, bladder recurrences as well.
Yeah, I think that's so great. And it's always exciting to see publications of, thousands of patients with, a rare disease such as upper tract urothelial carcinoma. So, that's such an accomplishment in and of itself, to put all of those together. So congratulations on that. Before we wrap this up, is there any other points that we've missed specifically to this study, or any points that you want to, point out about nephroureterectomy and bladder cuffs or upper tract in general?
I think the robotic approach does allow us to excise the entire intramural portion of the ureter from the extravesical approach, which was not that easily accomplished via an open approach. I think so. This particular approach, the robotic approach, not only duplicates the open approach, but I would argue does even better.
Yeah, that's an excellent point. Actually, I always remember in training when we were doing an open nephroureterectomy, and it took you back to kind of your pediatric times, of doing those in extravesical versus intravesical reimplants. So, yeah, I think that's an excellent point, and especially from a learning perspective, as trainees come out into practice doing nephroureterectomies and doing that dissection of the intramural, tunnel down to the bladder cuff from that extravesical approach with the XI robot. It's great.